Let us talk about short-acting nitrates. Glyceryl trinitrate, sublingual tablet or spray, acts for about 30 min. It is more useful in preventing attacks than in stopping them once they have begun. Patches containing glycerol trinitrate, transdermal administration, have a long duration of action, up to 24 hours. Long-acting nitrates are more stable and may be effective for several hours, depending on the drug and preparation used, sublingual, oral sustained release. Isosorbide dinitrate is widely used, but it is rapidly metabolized by the liver. The use of isosorbide mononitrate, which is the main active metabolite of the dinitrate, avoids the variable absorption and unpredictable first-pass metabolism of the dinitrate. Let us get to know about their mechanism of action. Initial metabolism of these drugs releases nitrite ions, a process that requires tissue thiols. Within the cell, NO2 ion is converted to nitric oxide, which then activates guanylyl cyclase, causing an increase in the intracellular concentration of cGMP in the vascular smooth muscle cells. cGMP activates protein kinase G, PKG, an enzyme that causes the vascular smooth muscle to relax by several mechanisms. These include activation of calcium pumps that sequester calcium into the smooth endoplasmic reticulum, circa, and extrude calcium into the extracellular space, PMCA, and activation of potassium channels, causing membrane hyperpolarization that inhibits calcium influx by switching off voltage-dependent calcium channels. The fall in calcium ions decreases MLC potassium activity, and relaxation occurs as light chain phosphorylation is reduced by MLC phosphatase, the activity of which is increased by PKG. Let us discuss adverse effects now. The arterial dilatation produced by the nitrates causes headaches, which frequently limit the dose. More serious side effects are hypotension and fainting. Reflex tachycardia often occurs, but this is prevented by combined therapy with beta blockers. Prolonged high dosage may cause methemoglobinemia because of oxidation of hemoglobin. Tolerance to nitrates may occur. For example, chronic penterythritol tetranitrate has been shown to produce tolerance to sublingual glyceryl trinitrate, and moderate doses of oral isosorbide dinitrate 4 times a day produce tolerance with loss of the anti-anginal effect. However, twice-daily dosing of isosorbide dinitrate at 8 a.m. and 1 p.m. does not produce tolerance, presumably because the overnight rest allows tissue sensitivity to return by the next day. Tolerance to nitrates is poorly understood, but depletion of sulfhydryl group donors may be involved because tolerance to nitrates in vitro can sometimes be reversed by N-acetylcysteine. Another possibility is that peroxynitrite formed from NO inhibits cGMP formation from guanosine triphosphate, GTP. A special caution that we need to look out for is the chest pain that is not relieved by 2 or 3 tablets within 30 minutes may be due to an acute myocardial infarction. In addition, nitrate administration may result in an increase in intracranial pressure, and therefore, these drugs should be used cautiously in patients with cerebral bleeding and head trauma. Let us move towards beta-adrenoceptor antagonists now.